Good morning and good afternoon. Thank you all for joining the next edition of the Ascensus webinar series about the clinical importance of cardiology-related secondary findings. Before we get started, I would like to introduce myself. I'm Elena Brazil, the head of marketing at Ascensus, and I'd like to also let you know who are going to be our speakers for today. So Dr. Elena Jarvis, she's our medical advisor at Ascensus. She's earned her medical degree at the Albert Ludwig University in Freiburg, Germany. And she's worked as a doctor over the past decade and has specialized in family and internal medicine and has also been focusing on cardiovascular disease. She provides us with a wealth of knowledge and clinical practice within the context of genetic testing, which is why I'm particularly happy that she would join today's webinar. And for those who have not seen her on previous editions of our webinar, I'd like to also introduce another great colleague, Dr. Alison Faber. She is the head of our product and customer service team here at Ascensus, and she has extensive background in research and diagnostic genetics with a PhD in physiology from the Medical College of Wisconsin, and has also done postdoctoral research in molecular medicine. And what makes Alison stand out is not only her deep knowledge in genomics, but also her passion in always providing excellent consulting to all our partners and customers. Okay, thank you again for your active participation, and I hope you enjoyed today's webinar. Over to you, Alison.
Okay, thank you, Alina, for the kind introduction. And I also want to thank you all for joining us today. I want to start with just a quick outline of what we're going to talk about. I will explain what secondary findings are and how we think about them, and then I'll hand it over pretty quickly to Elena so she can tell us the value specifically of secondary findings when we're talking about cardiovascular disease. And she has some really good specific tips for managing these patients who have cardiovascular disease related secondary findings. So here at our census, we are talking about genetic testing when we think about these secondary findings. And when we order a genetic test, we're performing it really to identify the genetic cause of some specific set of symptoms. So we think of this as the indication for testing or the primary reason for testing, resulting in primary findings. And historically, when we order a genetic test, we would order a single gene or maybe a panel test, which means we're looking at very specific regions of the genome, specific genes that are known to be associated with those symptoms that are the reason we order the test. So we're kind of limiting our search area and therefore limiting the types of variants we're going to detect. But if we think about these last few years, the direction we're moving in diagnostic testing is really towards exome sequencing, where we sequence all of the genes in the genome, or even genome sequencing, where we're sequencing the entire genome and detecting variants in these regions outside of genes that are associated with those symptoms for which the test was originally ordered. So what this means is that these results from exome and genome sequencing can include variants that are unrelated to that indication for which the test was ordered. So we can think of these as incidental, maybe unintentional findings. So things that we're finding outside of that primary reason. And we've known this for quite a while. About 10 years ago, the field of genetics agreed that patients would really benefit from having this information about these things that are, these variants that are existing outside of those targeted genes. So they formed a working group to identify these secondary findings. So what this group came together and found was a list of genes that they recommend be analyzed for variants that are unrelated, but can still cause disease. And these are called secondary findings because we're not finding them unintentionally, like maybe an incidental, but we're really looking specifically at specific regions of the genome that aren't associated with that primary reason for testing, but rather secondary. So what they've come up with is a list of genes that tries to balance the burden on patients and laboratories from being too large while still maximizing that potential to reduce morbidity and mortality in our patients. So we're currently, last year, the most recent list is version 3.2. This includes 81 genes. And there are really strict guidelines that are constantly evolving as the field evolves. But the four things that we try to think about when selecting these genes are that they're going to cause disease that have relatively high penetrance. So these are the monogenic disorders that are on the more common end. These are variants in genes that are going to have high penetrance. So the likelihood of that variant causing disease is high. These diseases are going to have a severe impact on patients. They could even be deadly. And importantly, all of these diseases have some clinical utility. So there needs to be either a treatment or a preventative measure that patients and physicians can take when we think about these genes. Okay, so we've set the list of genes, but we also need to think about what types of variants in those genes are going to be included in these findings. So it's really important that we only inform our patients about pathogenic and likely pathogenic variants in secondary findings, so things that we are sure will cause disease rather than uncertain variants. But these can be single nucleotide variants, small insertions and deletions. And importantly, there's evidence that copy number losses, either the entire gene or part of the gene, can result in disease in a majority of those 81 genes. All right, so if we think about all of the types of variants we can find in all of those genes, the prevalence of secondary findings in this list really varies study to study, but consistently between 3 and 5% of people undergoing exome or genome sequencing are going to carry one of these secondary finding variants. So based on that, the ACMG recommends that any patient, regardless of age, who is undergoing an exome or genome sequencing test should be offered secondary findings results. Now, the key word there is offered. So we need to obtain from each patient informed consent from the patient or their guardian. And we should keep in mind that reporting of these secondary findings is optional. We should ask our patients to opt in. So in order to get conformed consent, we really need to educate our patients about the benefits, burdens, and limitations of these results. So the benefits of receiving your secondary finding results are enormous. Because of that clinical utility, there are treatments or preventative tests that can truly be life-saving, not only in the patients who have tested positive, but because many of these variants are going to be inherited, their immediate and extended families can also benefit from this information. But this is a topic that I will let Elena really expand on in the second part of this talk, these specific benefits. But we have to acknowledge here that there are burdens to having this information. So getting a positive secondary finding result could lead to additional health costs and especially stress for patients and their families. Also, if we think about the types of patients who are undergoing exome and genome sequencing, typically they're children, and parents may not at this time want to know their child's risk of an adult onset disease, and that's a valid concern. Additionally, the children undergoing these tests are usually critically ill, and their parents may not have the emotional capacity at this moment to deal with any additional results. And these are things that are legitimate and we should take into consideration during this counseling session before testing. So finally, we also need to acknowledge the limitations of secondary findings in any genetic test. There are technological and methodological limitations in detection, as well as our incomplete knowledge as a field of genetics. This information is constantly growing and changes as new evidence becomes available. So based on these types of limitations, we can understand the residual risk. So, and by that I mean, if a patient has a negative secondary findings report, it never means that their risk of developing one of those disorders caused by the 81 genes is 0. We can never get rid of all of the risk. There will always be some residual risk. So these are things we need to educate our patients about so they can make an informed decision and hopefully opt in to really get the benefits of secondary findings. But if we think about the diseases that are caused by those 81 genes included in the current list, the ACMG breaks them down into 4 categories. So the first one is cancer phenotypes. This is 17 different disorders. I've listed here some more common ones you might recognize, like Lynch syndrome and BRCA1 and 2. Then the second are 4 different types of inborn errors of metabolism. We have Fabry, Pompe, biotinidase, and OTC deficiency. Then they have a catch-all category that's 7 different disorders, and I've listed them all here, like Modi, Wilson disease, and amyloidosis. And the final category that we're really going to focus on today is cardiovascular phenotypes. And we can think of this as containing 4 subcategories: the cardiomyopathies, arrhythmias, aortopathies, and issues with cholesterol metabolism. So at this point, I'm going to hand it over to Elena, and she's going to explain why we've chosen, of all the secondary findings, to really focus on this one category. Thank you.
So, why are we focusing on cardiovascular diseases? I would like to start, 1 in 5 people will die of sudden cardiac death, and half of them have no previous symptoms. A 20-year-old male American football player with an uneventful medical history until he developed 2 episodes of exercise-related syncopes. He reported palpitations and loss of consciousness during intensive physical activity. Family history was unremarkable, and clinical examination, blood testing, 12-lead ECG, all of these did not reveal any specific findings. Only transthoracic echocardiogram and cardiac MRI demonstrated a dilated right ventricle with a moderately decreased right ventricular systolic function. Myocardial biopsy was refused by the patient, and genetic testing was scheduled. Unfortunately, and against medical advice, the young man participated again in an intensive training and syncopated. He went into ventricular fibrillation and died shortly after, despite immediate electrical defibrillation and continuous cardiopulmonary resuscitation. Postmortem genetic testing revealed a yet undescribed pathogenic plakophilin 2 variant that leads to premature truncation and is associated with arrhythmogenic right ventricular dysplasia. Autopsy confirmed this diagnosis, and furthermore, an extracardiac sarcoidosis was found without any evidence of cardiac involvement. So this tragic case emphasizes the value of a thorough clinical evaluation. Cardiac MRI and genetic testing were and would have been of great value in an early phase of the disease and might have been life-saving. It also highlights the increased risk of sudden cardiac death for patients with inherited cardiovascular diseases participating in competitive sports. And there are so many other cases of young athletes like this one dying all of a sudden during exercising. We know about these cases as they may have often been reported in media. But it's not only the athletes that die at young age. Every week, 38 young people die unexpectedly from a heart condition they didn't know they had. So let's get started with the definition of sudden cardiac death. Sudden cardiac death is an unexpected natural death due to a cardiac cause. It occurs in a short time period, generally within 1 hour of symptom onset, in a person without any prior condition that would appear fatal. It affects all ages, all ethnicities, and men have a slightly higher prevalence. Causes of sudden cardiac death can be hereditary, where genetic predispositions play a significant role, environmental, where lifestyle and external factors contribute, and of course, some of the reasons remain unknown until now. 50% of patients who die from sudden cardiac death exhibit no prior symptoms. Nevertheless, there might be warning symptoms, like in the athlete I was just introducing before. It could be palpitations, dyspnea, a syncope, or chest pain. And these symptoms should always be taken seriously, followed by clinical assessment and diagnostics. But it's crucial to understand that sudden death is often the first clinical manifestation. So on the bottom line, sudden cardiac death contributes to 20% of all deaths worldwide, and survival rates are less than 1% worldwide and close to 5% in the US. Given the alarming statistics and the often silent nature of sudden cardiac death, it becomes clear that prevention is actually our most powerful strategy. Before we discuss the prevention of sudden cardiac death, I would like to draw your attention to the slide highlighting the different causes contributing to sudden cardiac death. At least 80% of patients who experience sudden cardiac death have a coronary artery disease as underlying anatomical substrate due to atherosclerotic changes in the coronary arteries, often caused and significantly influenced by environmental factors and lifestyle choices. These patients are typically older. However, another group, the inherited cardiac disorders on the left, primarily affect younger individuals. These are due to specific genetic variants passed down through families in a simple Mendelian fashion. They account for 20% of sudden cardiac death. So knowing the main causes for these entities, we can now look at how to prevent sudden cardiac death. While there are some differences, many preventive strategies are similar for both inherited cardiac disorders and coronary artery disease. In both, primary prevention of sudden cardiac death should start with identifying individuals at risk before the cardiac event occurs. Once identified, risk stratification, lifestyle modification, medical management and device therapy, and of course surveillance are important tools. Improvement of education and public awareness on sudden cardiac death risk factors and prevention strategies should and need to be optimized. But as you can see, there are some slight differences between the prevention box on the left for inherited cardiac disorders and on the right for the coronary artery disease. For the coronary artery disease clinical examination, including ECG, echo, stress testing, and of course, removing risk factors like smoking, unhealthy diet, and others play a pivotal role. For the inherited cardiac disorders, on the other hand, it's essential to thoroughly assess medical and family history, to conduct pre-participation screening for athletes, best before they begin competitive sports, and to perform genetic testing, especially for individuals suspected of having an inherited cardiac condition, as they might have had warning symptoms or a positive family history. Family cascade screening, which is on the bottom of the left box, is a key primary prevention tool for at-risk relatives, and I will discuss this in more detail later. And of course, there's secondary prevention that includes improvement of resuscitation as early as possible and treatment of survivors with optimal medical treatment and regular follow-up, and monitoring of patients with a history of cardiac arrest or life-threatening arrhythmias. When talking of inherited cardiac disorders, I would briefly like to show which are the conditions we talk about and where is the main problem. There are two large groups. Alison had mentioned them already before, and I like to go a little bit deeper. Primary electrical disorders of the heart are conditions characterized by abnormalities in the heart's electrical function, primarily due to variants in genes encoding for ion channels. When these channels are altered, it can lead to irregular heartbeats or arrhythmias, which we can detect with an ECG, and which can have significant clinical consequences. Examples include long QT syndrome, short QT syndrome, Brugada syndrome, and CPVT. So these conditions affect the heart's rhythm and are commonly known as arrhythmias. And then there are the cardiomyopathies on the other side, which are abnormalities in the structure of the heart muscle caused by mutations in genes encoding proteins essential for cardiac muscle functioning. So they primarily impact the myocardium, leading to changes in heart size, shape, or function, which may eventually become visible through cardiac imaging, like echo or MRI imaging. Examples include the hypertrophic cardiomyopathy, the dilated cardiomyopathy, and the arrhythmogenic right ventricular cardiomyopathy. These conditions can lead to progressive heart failure and secondary as well induce arrhythmias, which then cause sudden cardiac events. And I would like to briefly mention the aortopathies that affect the structure and function of the aorta and weaken the aortic wall, predisposing individuals to life-threatening complications such as aneurysms and dissections, and the cholesterol metabolism disorders, which are characterized by very high levels of LDL cholesterol caused by variants that impair the body's ability to remove LDL cholesterol from circulation, leading to its accumulation and by that significantly increasing the risk of developing early onset coronary artery disease and other cardiovascular complications at a young age. Moving on to our next slide, you can see the specific secondary findings related to the aforementioned cardiovascular disease. Each of these disorders can be caused by a variety of genetic variants, and the genes listed here are not exhaustive of all genes that contribute to the specific disorder, but the genes listed here are the ones that the ACMG list of genes that should be reported as secondary finding due to significant morbidity and mortality, and they are associated with these conditions, making them actionable through early detection and intervention. Like these three genes, CALM1, CALM2, CALM3, that have just recently been included in the updated ACMG secondary findings list version 3.2 that Alison introduced before. They have been recognized for their crucial roles in significant cardiovascular conditions that had not been known before. These genes code for a calcium binding protein that's involved in various signaling pathways, and it plays a crucial role in regulating calcium-dependent processes. For example, it regulates and modulates the function of cardiac ion channels. That's why it's called calmodulin. And cardiomyopathies are associated with potentially life-threatening cardiovascular conditions like long QT syndrome and CPVT. The key reason for their inclusion in the ACMG secondary findings list is that they meet all the aforementioned criteria that I have shown on the top of the slide. So now let's talk about the evaluation of patients with secondary genetic findings. Secondary findings are genetic testing results for phenotypes beyond that which triggered the genetic test. So in most situations, the individual will not have any evidence of the expected cardiovascular disease. So what shall we do with an individual identified with a pathogenic or likely pathogenic variant in a disease-causing gene with no phenotype? You start with gathering all disease-relevant medical history of index and family. This includes generating a 3-generation pedigree, which is really important. You provide genetic counseling or refer to a genetic counselor, and if necessary, that a genetic test result should be confirmed, verifying the pathogenicity of the variant and ensuring that the genetic test was performed by an accredited laboratory. Upon confirmation of the genetic finding, the patient should undergo a thorough clinical evaluation specific to the implicated cardiovascular condition. This will include several diagnostic procedures such as ECG, echocardiography, stress testing, MRI, and others. If a clinical diagnosis can be established, the patient should be treated similar to a phenotype-positive patient with a primary genetic finding. And cascade genetic testing with genetic counseling should be recommended for family members. Often individuals with a secondary finding have no signs of the disease and clinical diagnosis cannot be confirmed. Then physicians must decide on future surveillance and determine if the patient is at future risk, which is challenging, especially in children. The risk may be small if the patient is a lot older than the typical age of onset for the disease. But in most cases, periodic surveillance shall be recommended, particularly for children or young adults, but also in elder patients as there are cases with late onset, of course. Physicians should always recommend to their patients that they share the genetic risk information with all of their at-risk relatives, because any biological relative might share the same variant and either have the disease or be at risk for developing the condition in future. This is what we call family cascade screening. It's a genetic testing that starts with the first-degree family members and goes on to the second and third-degree family members. So for any family member who is found to be positive, for the disease or for the genetic test result, the next in line relatives should be screened and offered counseling. And this continues until all extended family members at risk have been offered clinical screening and genetic testing. Also, what you can see with the blue arrow and the blue box, if a family member is tested negative, this family member does not need to be under surveillance in future. Although there might be practical limitations to carrying out full cascade evaluations, especially when relatives are geographically separated or not in contact anymore, providers should make reasonable efforts to do so and by this save lives. Cascade screening is one of the more forceful demonstrations that molecular biology and genetics are not just a tool for researchers, but represent an important and by now essential component of good medical care. This is what Peter Schwartz said. And I'd like to talk about the impact of family cascade screening, starting with the benefits that arise from it. It allows us to identify at-risk relatives early. This enables us to implement risk management and reduce long-term morbidity and mortality by targeted prevention and treatment, as well as improved family planning. And it provides significant reassurance for non-carriers, as mentioned before. Knowing they are not carriers alleviates anxiety and allows them to focus on their health without the burden of potential genetic risks. But there's also another side. There are limitations and there are burdens that come with the testing of family members. Receiving unexpected information about potential genetic risk for a severe condition can cause feelings of shock, anger, anxiety, which need to be handled. Despite efforts to improve cascade genetic testing uptake, current literature reflects persistently low rates, with typically less than 30% of at-risk relatives undergoing testing. To improve testing and the uptake, the most promising approach involves delivery arrangements, which include direct contact with relatives, offering various methods of communication. You could offer a letter, an email, a telephone call, provide genetic counseling through telemedicine, or streamline access to genetic testing services. Then there are communication challenges. So informing relatives about their genetic risk can be problematic, as not all probants wish to share this information. Also, there are concerns that genetic information could be used by insurance companies or employers to discriminate against individuals with genetic predispositions to certain conditions, although many countries have implemented laws to protect against such discrimination. And last, there are health system barriers, meaning various factors, including lack of family-centric care models, limited reimbursement, shortage of genetic specialists, and other factors that significantly hinder the effective implementation of family cascade screening for inherited cardiac disorders. I'd like to talk about special considerations for cardiovascular diseases. There's a large variability in disease manifestation and severity among carriers. And these are, and that's why we're discussing it on this slide, specific for cardiovascular diseases. Genetic modifiers are additional genetic variants that can alter the phenotypic outcome of a primary disease-causing variant. These modifiers can either exacerbate or mitigate the severity of the disease, leading to different manifestations in different families. There are epigenetic changes or epigenetic modifications which affect gene expression without altering the DNA sequence. They can also contribute to interfamilial variability. And there's variable penetrance and expressivity. So penetrance refers to the likelihood that a person carrying a particular genetic variant will exhibit symptoms of the disease. A reduced penetrance means that not all individuals with a variant will develop the disease. Variable expressivity refers to the range of symptoms that can occur in individuals with the same genetic conditions. Both reduced penetrance and variable expressivity can result in different disease manifestations among families carrying the same genetic variant. And of course, but this is not specific for cardiovascular diseases, environmental factors such as diet, physical activity, smoking, and other factors interact with genetic variants. and can influence disease outcomes. All of these factors can vary significantly between families, contributing to differences in disease manifestation. And we shall not forget some disorders remain genetically unresolved up to now. Having discussed the theoretical factors contributing to the variability and differing severity of manifestation of genetic diseases, before we will come to the end of the webinar, I'd like to present a study that was done in a South African population, investigating a founder effect of the KCNQ1 mutation, which is associated with congenital long QT syndrome. The study population included 320 subjects with 166 mutation carriers and 154 non-carriers. Among the mutation carriers when not taking beta blocker therapy, there was a notable phenotypic variability, particularly in the QTc values, which ranged widely. And there were also 12% of mutation carriers with a totally normal QTc interval. Furthermore, the severity among symptomatic carriers also varied significantly, depending on factors such as heart rate, QTc duration, and specific mutation carriers with a QTc duration of more than 500 milliseconds and a heart rate of more than 73 beats per minute were at a higher risk for cardiac events. So looking at the second graph, among the 166 mutation carriers, 79% have had symptoms, with a median age at first cardiac event of 6 years. Symptoms range from syncope with complete loss of consciousness to aborted cardiac arrest requiring resuscitation to sudden cardiac death before the age of 20 years, which occurred in 23 individuals. But there were also individuals that were carrying the mutation but were asymptomatic up to the time of examination. These findings highlight the large variability in disease manifestation and severity among carriers, underscoring the importance of genetic and environmental modifiers in the expression of congenital long QT syndrome. And they indicate the risk stratification for long QT syndrome patients must be more individually tailored and may have to take into account that specific mutation and probably additional relevant factors such as heart rate and QTc interval of the individual patient. As we've covered a lot of information in the past 30 minutes, I would like to recommend this consensus statement paper. It serves as a reference document for clinicians to determine whether genetic testing is indicated for patients with inherited cardiac disorders and their relatives. It provides strict criteria on who should be assessed and recommendations on which genes should be examined. So to summarize, secondary findings in genetic testing provide valuable insights beyond the primary reason for testing. Secondary findings have significant implications for the prevention, diagnosis, and management of cardiovascular disease. Effective management of secondary findings can improve outcomes and reduce morbidity and mortality rates for patients and their families. Large variability of disease manifestation and severity among carriers underscores the importance of thorough screening. And of course, ongoing research and technology advancements will further improve patient care. And this is where I would like to end our webinar, and I would like to pass on to Shivendra Kishore for the question and answer session.
Thank you, Ellen, and thank you, Alison. This was one terrific session for me. Once I start having a feeling I know something about the field, I come across these talks where I feel I still have to learn a lot more. So thank you for this very insightful session. We have a few questions, and I would start with, what is the difference between incidental and carrier findings?
That's a great first question. I'll take that one. So in an exome or genome report, in addition to the primary, we often will include when informed consents obtained, these incidental findings, which we've been talking about today, that include the secondary findings. And these are variants in patients that can cause disease. Maybe it's at a later age, but these are variants that could cause disease. The other section of the report, these carrier findings, these are variants that we found in the patients, but they won't cause disease in that patient. They're autosomal recessive or X-linked, but this patient will be at risk of passing those variants on to their children. And their children could develop disease when inherited with a second variant. So they might look similar or sound similar as they're carrying both types of variants, but really functionally in the index patient, they have a really different impact.
Thank you, Alison. There's another question perhaps to Elena. In the environmental factors that you talked about for cardiovascular diseases, which factor is the most important according to your findings?
Well, the environmental factors that play a role in manifestation of cardiovascular disease are the diet, the physical activity, and factors like smoking or general risk behavior that is commonly known. So limiting for patients that would have a risk for developing coronary artery disease, those risk factors like quit smoking, have a healthy diet, would have the most improvement for their health.
Thank you, Elena. Another question in the direction of incidental finding. Is there a difference in the number of incidental findings reported in genetic disease patients typically who are coming to you compared to the random healthy population, which perhaps might be the number coming from different databases?
We have discussed about this point recently, and the number that we see in our patients, which is a cohort of rare disease patients, is approximately 2% of the patients, but literature also states 3.75%, up to 5%, I think. So if we look at a healthy cohort that has no indication for primary testing, no phenotype, and we would do a whole genome sequencing, it would probably be consistent with these numbers. Approximately 5% of healthy individuals would carry a secondary finding. This is a number that was found in some studies, and it will of course be increasing because detection methods will become more and more valuable, and more genes will be detected that we could find.
Thank you, Elena. One question which is, does attitude affect the mutational change?
Maybe it means the impact of stress in cardiovascular disease. That's a thing we think about often.
Correct. As perhaps I would assume your outlook towards life, and which is reflected in the stress. So would that have an impact?
As Alison said, the amount of stress and the attitude could have an impact, as many psychological factors contribute to somatic diseases. But in general, if there is a genetic variant that would be disease-causing, there might be only a small range of severity or disease manifestations that would be contributed by the attitude.
Thank you. I think we mentioned that already. Only likely pathogenic variants are reported for secondary findings. So what if you identify a VUS, which is later on reclassified into pathogenic, likely pathogenic? Are we reporting it? And how often does this happen? Considering I see that different labs across the world work on these secondary genes. So it might be that there's a higher likelihood for reclassification because lots of people are focusing on these genes, or it could also be possible that the variants are rather well studied by now. So the likelihood of having a VUS being reclassified is low. How do you see that?
I think the latter, that most of these genes or all of these genes in the 81 are very well studied. And we know a lot of the mechanisms of how they work, but it is always possible to find a VUS and it could later be reclassified to likely pathogenic or pathogenic. And in that case, it is essential for the lab to issue that new updated report informing people of that change as soon as it becomes available. This is really valuable information. And that's one of the benefits of having whole genome or whole exome sequencing over a panel, is that you have the data available for those people to go who contain the variant to go back and look and then reissue the report with the new information rather than redoing any sequencing.
There's one question connected to that. You mentioned that there are now 81 genes. When we started around 10 years ago, there was around 57 genes which were in the secondary findings list. How do you see the numbers growing, especially when the whole genome sequencing is being absorbed as a routine line testing across many countries? Will it become so many that it would become a threat or would cause fear, or would it be something that people would be happy to have more control on their life, especially when people are embracing whole genome sequencing to have a better, healthy lifestyle, not only for disease patients?
Yeah, that's a great question and a big question, because the ACMG working group does try to balance that added stress. They definitely don't want to provide so many that either they're not actionable or the likelihood of developing disease is low. So that's definitely a balancing act. But really, we've seen a consistent, not an enormous increase in 10 years, but we're consistently adding genes to that list as new information becomes available. So like the calmodulins, and recently we think a lot about penetrance. So as more data becomes available, we can more accurately understand how variants in genes increases the penetrance or the likelihood of developing disease. And as those numbers become more accurate, genes will be added. But on the other side of that coin, in that paper, the other gene that they were considering adding was ATP7A, and it was excluded because the treatment wasn't considered effective enough. So it's not only research in genetics that drives that list, but actually treatment and prevention in the clinic also really contributes. So as that grows, this list will also grow.
There is one question which I think I should have thought of, but I never, and it's very interesting. The question is, do you have any studies or researches that explores the effect of autosomal dominant genes in homozygous statuses? So that is, does it have a clinical evidence with an earlier or severe presentation?
Yeah, that's an interesting question. There are some diseases where that is true, but conventionally, to have a homozygous autosomal dominant variant would not be consistent with life. Yeah, this would be unusual in most diseases to find that.
Thank you, Alison. So I think in the interest of time, we are just 1 minute ahead of it. So I would like to close the session. I would like to thank both the speakers, and I would also like to thank the audience. Hope everyone enjoyed the session, and we are looking forward to see you all again in the next webinar. Wishing everyone a lovely day ahead. Thank you so much. Bye-bye.